oncologists. I have the privilege of actually being Sid's oncologist. And we were just talking, it's probably been almost 7 years, and Sid continues to be in remission for all the progress we've made in myeloma.
Wonderful.
And the amazing thing, I think the amazing thing, if you look around this room, I defy you to figure out who are the patients, who are the patrons, who are the researchers, and who are the doctors. Because people with myeloma now are doing so amazing. The reason that people with myeloma are doing so amazing is because of the amazing research that's being done with myeloma. This is a disease from when we all started was a death sentence and people did poorly. And now people continue to live, and we do better and better and better. With each new advancement and each new drug that comes out, people continue to live longer and longer and longer. What we want to do tonight is talk about hope and talk about how we're starting to defeat this disease. I see myeloma is on the run, and the cure for myeloma is around the corner. And the panel that we have tonight is going to talk about how we're doing things to defeat myeloma. But more importantly, when we did this in the past, we used to give these big, long lectures, and no one quite understood what we were really doing, and everyone politely just sat there. Tonight, my job is to be a host, and what I want to do is to answer your questions about myeloma. So we've assembled an expert team who treats myeloma in various aspects of myeloma, and we're going to really have the audience make this an interactive session. So I'm counting on your questions to really drive this. So what I'd like to do first is just for the panel to introduce themselves.
Dr. Harold Barbaros. I've been doing hematology, oncology for 40 years. I'm the old man on the podium. And I've seen all the changes.
I'm Dan Coriel. I was at the University of Michigan directing the bone marrow transplant program until last year. And I was very flat. Now I'm at the University of Utah as the program director for bone marrow transplant. And they invited me over again, and I'm thrilled to be here in Michigan for this event.
Hi, Jeff Sonder, and I run the myeloma program at the Cumanos Cancer Institute, pretty much around the block, and it's nice to be back at this event. Great event.
I'm Craig Cole. I'm from the University of Michigan. We're the school up north. I went to Ohio State, so.
Hi, I'm Joan Levy. I'm VP of Research at the Multiple Myeloma Research Foundation. And on behalf of the foundation, I really want to thank Sharon and Sid Moss for this amazing event. This is my third year here, and we have an excellent panel of doctors here to answer your questions. And I think it's going to be an exciting night and a yummy night upstairs. And I just want to also thank Takeda, BMS, and Celgene for their support for this event.
Sure. When I get things started a little bit, I think a lot of people here know what myeloma is. Some people don't know what myeloma is. So maybe Dr. Zonder, if you could just explain to the group what myeloma is, what this disease is, and what we're trying to do.
So multiple myeloma is a type of blood cancer. It's a cancer of plasma cells. Plasma cells are the cells in your body that make antibodies, and antibodies are a protein that we can measure in the blood. Myeloma plasma cells, or cancerous plasma cells, make a type of protein called an M protein, and both the cells in the bone marrow, those cancer cells, and occasionally the protein that those cells make can cause problems for patients with myeloma. When we're teaching students and patients about the disease, we talk about the CRAB symptoms, C-R-A-B, calcium elevation, renal injury, which is kidney injury, anemia, and bone lesions. Any of those can be a presenting symptom. The bone lesions in particular can be a problem, a source of pain for patients. Also without fractures, but also can put patients at risk for developing fractures. And so multidisciplinary management of myeloma patients, we as hematologists or oncologists direct the anti-cancer therapy, but patients with myeloma often have orthopedic physicians involved with their care, often have kidney specialists, or other specialists involved with their care along the way. Transplanters particularly play an important role in the management. We treat myeloma by targeting those plasma cells, those cancerous plasma cells, and by controlling those, by suppressing those with therapies, we're able to prevent these symptoms that I just mentioned.
So the plasma cells are the bad guys, and we basically have got drugs that we use to try to kill off the bad guys, and these bad guys are doing damage to the body. And sometimes we need other doctors to help fix the things the bad guys have done. They can damage bone, damage kidneys, they can make blood counts low, and that's all the supportive care that we use to take care of myeloma. Now, anyone have questions about what myeloma is, or open it up right now? Please.
Doctor, I'm not sure if I understand what the symptoms are. What does an individual initially experience when they have this disease?
Sure.
A lot of patients that have myeloma will, in the very early stages, experience fatigue. The fatigue can come from a number of sources, particularly anemia. So 60% of myeloma patients that present will have anemia. They can also have fatigue from having high calcium levels in the blood. So when people have high calcium, they can get very sluggish and fatigued. So that's another sign. Again, fatigue is another sort of presenting sign. Also, when people have myeloma, just like Dr. Zeiner had mentioned, they can have renal or kidney damage. When people have kidney damage, their urine doesn't necessarily change, but they don't clear the poisons out of the body to the urine like they should. And then, of course, having those poisons in the body then causes more fatigue. So fatigue is one of the very first things that people can have and through the disease. And then as the disease causes problems with the bones and causes holes in the bones, and people can have pain. And then one feature that we think about, sometimes people say the crab eye or the crab E, and the eye being infections. That when people have unusual infections, so not a couple colds or flus, but having in the hospital pneumonia, followed by another in hospital with pneumonia, because the plasma cells are part of the immune system, when the immune system becomes cancerous in myeloma, they can have recurrent infections because the immune system is impaired.
Dr. Hill, any other comments about that?
Myeloma can affect, it can present in multiple ways. Weakness, fatigue, lack of energy, you're anemic. Platelet count's low, bulbar bruises, your white count is low, your immune system has infection, the bones are involved, you roll over in bed, you broke a rib, you broke a hip. All the organ systems could theoretically be involved. So it's a really multidisciplinary approach.
One other thing, is that increasingly patients are diagnosed without symptoms. We do blood work as part of routine medical care much more than we did, historically, more than we did 30 years ago. So there are a lot of patients who don't present with very specific symptoms. Recently, the diagnostic criteria for myeloma have been revised to include certain subsets of patients who don't right now have symptoms but have such a high likelihood of developing symptoms in the next few years that we're actually starting to pull therapy forward and start treating some patients, not all, but some patients who we used to call smoldering myeloma. There are many patients who meet the criteria for a diagnosis based on what's going on in their bone marrow, who have no symptoms. That's what I mean by smoldering myeloma. And sometimes you can watch a patient like that for a few years, several years in some cases. But there's a high-risk group within there that, based on what's happening, based on how many plasma cells are in the bone marrow, or what their bones look like on very sensitive imaging tests like MRIs, who might actually need treatment even though they're not specifically experiencing a symptom. That's a very recent development within the field. That's like 2015.
The question controversial, by doing that, taking that asymptomatic person who feels perfectly okay, no symptoms whatsoever, and you do a very aggressive therapy, is there a survival advantage?
We don't know that yet. Clearly, that is clearly the crux of that, the issue right there.
So sometimes what will happen is someone will get an insurance physical, and part of that insurance physical will draw a protein as part of a routine physical, and that protein will come back abnormal. Those patients can sometimes now be diagnosed with myeloma. And the big controversy for the group up here is to look at people who are completely asymptomatic, they've got a funny protein that they can potentially go for years and years and years without requiring any treatment. Should we treat those patients? And maybe we can start, one at a time and just kind of address, should we treat people? How much should we treat people?
I haven't made that step forward in my patients yet. I'm from the old school, asymptomatic patient. If it's not a curable disease, you got to show me that I increase survival. You have to show me that person will live longer for me to give the possible side effects of this disease. It's important. They do these kind of studies, but I haven't made that jump yet that other people have.
Yeah. So, I want to look at you because So, and I've learned a lot. I mean, I transplant myeloma, and I learn myeloma from people like this too. But actually, I think that my approach has been, yes, there is a huge area of controversy now, like Dr. Zanda said, regarding the risk stratification of people with smoldering myeloma. Myelomas are not yet fully expressed. But there are some cases, and usually this is driven by the DNA the features inside the myeloma cells that we consider to be at very high risk. And if these people are healthy and young, and if they have more than one risk feature, I think that some of us move on to treating them aggressively. I'm not going to give you a list of what these risk factors are, what the worst are, but I think that we've done, at least in a couple of patients, that the approach is very, very personalized, very individualized. So, I mean, on these couple of patients, I mean, I discussed the cases here with Dr. Cole, and, we both had to agree that this was the right thing to do. But, it's not something that is done routinely, casually, and some people certainly, prefer not to yet act in it. So, what do you think?
Well, so there's a whole spectrum of patients with asymptomatic disease.
Yeah.
And we are, we're able to assign some prognosis to these patients, and we can pretty much, break a patient down, into groups ranging from sort of the earliest, least aggressive group, which has maybe a 5% chance over the next 20 years of developing symptomatic myeloma, to somebody who has an 80% chance in the next 2 years of developing symptomatic myeloma. And those are obviously, very different situations. And it's that latter group that's sort of been pulled into the patients that are treated without symptoms, if they're going to be. I think, one thing that's certainly come up in the last, with this change is all of us, up here have patients who in 2014 were told they have smoldering myeloma and we don't treat you without symptoms, and in 2015 would meet current criteria for consideration of treatment. And I think the practice across the country with this group is not to just suddenly change the treatment plan and start treating these patients who you've been observing, which right there tells you that there is room, as both of you said, for individualized treatment. I think at the least, though, that highest risk, 80% risk group, that's a group you have to follow a lot more closely for symptoms than the low-risk group. And it's also a group that I think as you know, myeloma specialists, we're obligated to look hard to make sure they're truly asymptomatic. So go the extra step and get the best resolution bone imaging. Make sure that you've done urine tests. Make sure that you're following them, you know, every 2 to 3 months, not once a year like some of the lower risk patients.
I'm so excited this is our first controversy. We're waiting, when are we going to you know, I'm especially excited about this particular question because, you know, there was a paradigm shift that happened just last year where the people who were identified, their patients, myeloma is very, very different from person to person. And the reason now we call it multiple myeloma is that the biology of the disease is different in every individual. So it's not a cookie cutter type of cancer, but it needs to be very individualized. And one thing that we found out is that there's an ultra high risk asymptomatic population that biologically really has a nearly inevitable risk to turn into myeloma. And those are the people who we really consider for treatment. The non-ultra high risk, so the majority of the patients that have smoldering myeloma, is an incredible area of research that is currently being undertaken to see. And the big question is what if you do treat this disease earlier with non-invasive, non-toxic medications? Could that actually lead to better outcomes? And that is a huge controversy that will be answered by the research that is being started actually at our institution 2 weeks ago. And Jeff's going to have the Dana-Farber trial. I don't know when you guys are going to have that, but that it is such an exciting area that is opening up there.
I'll work with the MMRC. There's 2 trials right now.
Sure, so I'm not a treating clinician, so I can't comment from the clinical perspective, but at the MMRF, we have a sister organization called the Multiple Myeloma Research Consortium, which is composed of 22 academic and community centers that works on phase 1 and phase 2 clinical trials, of which Carmanos and University of Michigan are part of. And we're really excited because when I first started, I would always ask, well, why aren't we doing clinical trials in smoldering disease? And that was 7 years ago. Well, with these new definitions of high-risk smoldering, we started 2 trials in the consortium, or a part of 2 trials in the consortium. One is testing a very promising antibody. It's called an anti-CD38 antibody, daratumumab, in smoldering patients. And now we're also testing another antibody, elotuzumab, in combination with Revlimid index in smoldering patients. And I really think, and there's other trials going on, I really think that in a certain amount of time, we'll really see if there's benefit in treating this disease earlier and in terms of lengthening progression from smoldering to active myeloma and also overall survival in general.
I think the thing that we all have to be very, very careful of is just because you can doesn't mean you should. And Will Rogers once said that during the Great Depression and the Great Dust Bowl, all the people from Oklahoma moved from Oklahoma to California, and the IQ went up in both states. And that's the definition of lead time bias. And one of the things that happens is if you move all the people who are in the smoldering group into the myeloma group, the smoldering group even looks better. And some of the people who smolder for 10 or 15 years. And then you take the people who are going to go 5 and 6 or 7 years and you move them into the symptomatic group. That group actually looks better. And then you're not sure if you've really made an impact with the treatment. And because all the treatments that we have got side effects, we have to be very careful about what we do and who we treat. And the kind of research that we're doing, getting at the genetic level of these cancers, trying to figure out precisely who needs to be treated. But even if you predict that someone has an 80% chance of becoming symptomatic, well, maybe they went 2 years and they didn't have to take any drugs. You could wait when they got symptomatic. And so the smartest doctor is the person who treats you the day before you became symptomatic. So this is why this is such a controversial issue. And that's why when we talk about myeloma with people, we have you sit down with each of your treating doctor. You think about when you treat, not if you can treat, because now we've got so many drugs and so many ways that we can treat people. It's now just a matter of timing of when to treat and when to intervene.
All set.
I absolutely agree with everything you said about the effect of this changing definition and what it does to the statistics of survival for both groups. 100% correct. And we are as a research community conscious of that. But there's actually one other layer to this, which is, in the United States, particularly, the ability to do a randomized study to answer the question that we all want to know. Right? I mean, does it improve survival down the road? And the issue is that in asymptomatic patients in the United States, when they, at the end of the conversation, the first conversation or the end of the first evening spent on the internet reading up on this topic, they generally have an idea of whether or not they are in the I don't want to be treated yet camp or the I must treat this or I will never sleep again camp. Right?
The doctor we're missing on the stage here is Dr. Google. And Dr. Google has really become
Right.
an important part of taking my
And so, but it's true. And so the problem is that the actual ability to do a randomized study in the United States in this patient population is extremely limited because patients don't. I'm not putting it on patients, but it's the fact is very difficult to persuade a patient to be randomized because they generally have an idea of what they actually want to do after discussion.
Everyone know what randomization is?
Randomization means, to prove if a therapy improves survival, what do? You compare it to something else, right? And in smoldering myeloma, the standard of care in 2014 and really 2015, except for this recent subgroup, is no treatment. And so you're not comparing treatment A versus treatment B. You're comparing treatment A versus sitting tight, right? And those involve very different things. Those mean very different things for patients. I mean, starting treatment is a big decision. The side effects can be a big deal, and it's hard to persuade somebody that believes they ought to be on treatment not to take treatment because a coin was flipped in a computer somewhere and it says you don't get treatment. It's also, likewise, it's hard to convince somebody who doesn't want treatment to take it when they're not having any symptoms, right? So it's going to be very difficult. Not that we're not trying, but it's very difficult to do randomized research.
It is, and I've done quite a bit, and I think it's always a matter of how you discuss it with the patient, particularly, if you spend some time explaining that we don't have an answer, and we might as well. You're going to do better without my bias, and
Right.
But I was going to ask you something about the study on smoldering multiple myeloma. Why? So I think it's a great idea to do randomization between intervention and no intervention. But what I don't understand is why we're intervening with an anti-CD38 antibody versus standard care.
That is exactly the difference between the line between them is antibody.
Because you're introducing
and I
a
think,
problem, right?
yeah, well, so the one thing that we know, which is a breakthrough, and that's actually, I think, incredible, is that every plasma cell in the body, good and bad, has a little tag on it that says I'm a plasma cell. And there are several tags that are on the malignant plasma cells, the myeloma cells, that say I'm myeloma. One of those tags is called CD38, and it is a tag that is on the cancer cells. And a lot of the therapies that we've been doing up until this point have been really trying to target the internal biology of the cell, so of the cancer cell. So we're trying to change how the engine works inside the cancer cell to keep it from running. instead of actually attacking it from the outside by using its license plate. And so the antibody therapies are man-made or researcher-made antibodies that are built against the myeloma cells using that CD38 tag so that it selects out the cancer cells and leaves the remainder of the cells alone. And so part of, so why would we choose to use antibody therapies for smoldering myeloma? Well, one thing is it doesn't mess with the engine inside the other normal cells. That it doesn't, that it is truly a targeted therapy in that it seeks out just the cells that have the tag CD38. And so it doesn't hurt the DNA, it doesn't hurt the mechanism of action of any of the other cells, it just seeks out the CD38 cells, which makes it attractive in that it doesn't have, that we know of, it doesn't have any long-term effects on the biology of the remainder of the body. The question is two things. Is one, again, as much as I would love to say it is completely targeted, it probably isn't. There's nothing that is perfect in this world, and probably the target isn't as perfect as we would like it to be, and that is a continuing area of research. The second thing is that these drugs have been around not very long, and we don't, as much as I like to think that we don't know the long-term side effects, we really don't know the long-term side effects. And so those are the two, the thing that I think is attractive about the antibody-only therapy is that it targets the plasma cells. I don't think that it hurts other cells, and that, and if it does work, it could eliminate the plasma cells so people won't get myeloma at all.
The other thing the antibodies do, in addition to targeting the tumor cells, is they also are able to bind to some of the immune cells and activate them. And in activating these immune cells, the immune cells will now recognize the tumor cells and destroy them. And in a smoldering patient who hasn't had, therapy and whose immune system might be more intact, it might be considered that some of these antibiotic mechanisms might work better in smoldering or earlier myeloma disease, so that they could also make use of the body's immune cells in recognizing the myeloma tumor
I
cells.
think the word of caution, though, is as you do studies, the other thing that can sometimes happen is that you select the CD138 cells out, and what you happen when you actually develop myeloma is disease that doesn't express that, or could be a more dangerous disease or a harder disease to treat in the future. And that's the problem with other diseases that use these antibodies. Eventually, the cancers go undercover, they lose the license plate, and then you don't have anything to track them or use them. And that's always the problem as you do things early, is you may have kind of used up your silver bullet that you used at a later date.
So that's actually one of the arguments for using combination therapy. So an antibody plus chemotherapy is you're hitting it from different angles, and you're not allowing, you're trying to head off resistance to one agent. The other reason to think about combining agents is because there are certain antibodies. So elotuzumab is one of the ones which is different, doesn't target CD38, targets something different on plasma cells, and activates the immune system, and preclinically there's synergy with certain other anti-myeloma drugs, so like Revlimid, lenalidomide. So we don't know, we don't have all the answers. I mean, between us, and expand this panel to the myeloma research community around the country, there's not a consensus on this question about the timing of starting therapy, or are just antibodies the optimal approach? Is chemotherapy, or is chemotherapy plus antibodies the optimal approach? The fact is we're doing multiple studies simultaneously around the country in this area, 2 within the MMRC alone, that really are taking very different approaches to the same disease. And I mean, what we're hoping that we're going to eventually be able to do is pool data from multiple studies and try and get a sense of how it all shakes out.
And for most of us, this area is controversial. But once people have myeloma, and they have symptomatic myeloma, some of the concepts that Dr. Zonder was talking about, it's exactly what we do, which is we combine treatments. And in that case, we're using a sledgehammer. We're throwing most of the things we can at it to knock this thing out and put it in remission for a long period of time. And that's why most people, when they start out getting treatment, get combinations of therapy. We talk about combinations of therapy, stem cell transplants, and putting things together. Then even after stem cell transplants, continuing people on maintenance treatments and other treatments. So it's really, you know, do you want to do that right at the beginning when people may go a long time? Because all these treatments have got lots of side effects. And at the same time, you know that if people get into trouble, you have something that you can get them out of trouble. But let me open it up again to the group, please.
Are there any other types of blood or bone cancers that that's the research that's coming out of your group is fast tracking or helping to treat? Or
So there's a group of disorders that I would consider plasma cell disorders. So there's another disorder called amyloidosis. That's another disorder that's very related to myeloma. A lot of the treatments that are in for myeloma are applicable to people who have amyloidosis. There's another disease called light chain deposition disease that can also be applicable to this. There's cousins of myeloma called Waldenstrom's macroglobulinemia and other plasma cell disorders, and those disorders share a lot of things in common, and a lot of the treatments that we develop for this we can use in other diseases, and they cross over. Please.
What's the quality of research that's being done in other countries, and what kind of cooperation is there?
Dr. Levy?
Well, there's a lot of international research that's being done in myeloma. I'm pretty familiar with the different places worldwide because the MMRF has, part of what we do is we provide research funding internationally. We've given out about over 350 grants since the inception. There's a lot of research being done in the US, but in terms of France, Spain, Italy, as well as other companies, there are major myeloma centers doing research. We just had an international meeting in Rome, which was very informative, and all the investigators worldwide got together to share their research and findings with one another. So it is not limited just to the US, it's really an international effort. There are different, doctors here could talk about a little more, there might be some differences in treatment regimens used in different countries, but again, there is a tremendous amount of work going on in, you know, especially the places I delineated as well as outside of Europe in terms of myeloma research.
It's probably worthwhile. Why don't you just touch a little bit how MRM formed and how, before MRM, how things were disjointed, how this really put the community together?
So, you know, in 1996, when Kathy Busty, who is now a founder and now chair of the board, was diagnosed with myeloma, basically, she was going to be offered the same treatment as her grandfather was offered 2 decades before. And having the energy that Kathy has, and with her twin sister, she formed the Multiple Myeloma Research Foundation in order to be able to conduct more research, provide more research funding in the U.S., but also worldwide in a number of different areas of research. About 6 years later, she formed the Multiple Myeloma Research Consortium, which I mentioned before, which is a consortium of 22 centers that works together. We work together on tissue banking, genomics, as well as phase 1 and phase 2 clinical trials. And the reason why we formed that consortium was really to help speed drug discovery. Bring academia, large community centers together with industry to form partnerships so we could rapidly advance different drugs to the clinic. And so far, the consortium has run about 60 clinical trials with over 30 new agents together. So again, it was really funding research initially to academia and supporting that. And we also had grants to biotech, but also to be able to perform in a speedy way, bring new novel drugs to the clinic and really form a partnership between academia and industry.
I want to touch a little bit about the COMPASS trial. You mentioned it last year, and maybe you can update people where it is. This is
Sure.
the kind of research that can be done with the group.
Yeah, this is an amazing effort. As I said, the consortium worked on different types of genomic projects. So we would get bone marrow, separate out the tumor cell, the myeloma tumor cells, and sequence those and to see what different genetic and molecular alterations were present. And what we found was in a given myeloma patient, there are at least 4 to 5 different populations of myeloma cells that are genetically distinct, which makes sense with what you've heard from the clinicians here, that you're going to have to treat myeloma with different types of combination approaches. If one drug might, kill one clone that's present in your myeloma tumors, and another drug might be needed to get another clone. So what we decided to do out of that genomics initiative is say, we want to follow at the molecular level and clinical level 1,000 newly diagnosed patients from the start of their disease and when it progresses. And we want to really dissect out different molecular components as well as follow their disease clinically every 3 months, collect information. So we could associate different genomic alterations with different clinical responses, prognosis, as well as other parameters. I'm really excited to say, and Hermanos is a big contributor, Dr. Zonda has done amazing with putting patients on the trial. We now are celebrating, well, last month we celebrated our 1,000th patient enrolled, so we completed enrollment. Something that when I thought about in 2011 when the first center, WashU, opened, was going to be, oh my God, how are we going to put 1,000 patients on this study? And I'm so pleased to say we have these 1,000 patients on the study with over 80 to 100 centers. And now we have their molecular features and clinical features at the time of diagnosis. Now we're looking at them upon progression and relapse. And what I have to say is, if you ask me, well, how many patient samples do you have for relapse? And I'll say, well, we don't really have that much. Well, why is that? That's because many patients, 80% of patients are not relapsing for, 5 to 7 years later. And it hasn't been that long since the inception of COMPASS. So, we will be getting samples once patients relapse. But again, we're following these patients, and a lot of, the majority are doing really well. So I'm really excited about that.
So one of the things I think is also a little bit different, maybe the panel can comment, is what relapse is. Relapse used to be, you came in and you had those crab symptoms again. Now what most of us see as relapse is little changes in protein, little things that happen. And now, most of the time, we don't let people have full relapses because as we see the protein change, we tweak the treatments that they're getting, and all of a sudden people go back into remission.
Can I just, there was one thing you did not brag about the COMPASS study, which is that one of the most amazing things about it, besides the sheer scope of the study, is the fact that the data, this is an unbelievably, like an unprecedented database, and it's all being dumped publicly, like it's all out there. It's released and it's available to researchers around the world to analyze, to dig through. This is not something that's being guarded closely. This is something that's being generated and released, and then more information is generated and released. It's one of, honestly, one of the greatest collaborative research efforts that's ever been done in blood cancers. It's a really fantastic project.
Forgetting that, that's a really important component because that information we need to gather that information and make it publicly available. So researchers and scientists, clinicians can look at it. We're also collaborating with a company, and they're doing analysis, trying to look, put it all together and look at the pathways that are involved. And they're releasing that information back to the investigators so that they can form hypotheses. And then what happens? The hypotheses start to get tested. So again, thanks for pointing that out, Jeff, but that is a very exciting component.
The past was that research was the trade secret. Whoever was doing the research wanted to hold their information, keep it so they could generate more research. And what's happened with this is now it's public, so anybody can grab into this research and then generate more hypotheses, generate more drugs, and expand the development of drugs.